One is an earthquake in Taiwan about a decade ago. They report this finding that I already mentioned in my introductory remarks, that about 1 in 3 people will have a post-traumatic stress response that's pathological. And perhaps 16% will have a major depression. These rates very typically are about twice what one normally experiences in an epidemiologic survey on these problems. But perhaps the most important observation is about help-seeking behavior, the fact that only 1 person in 4 who might need care was found to seek treatment. So we know we have a very special problem of providing outreach to identify people who are in need but do not come forward. And we have a very difficult problem in sensitivity to their resistance, but recognizing their need. The next slide introduces Katrina, which is an interesting case of a hurricane and a flood, a double disaster. There are a number of papers that have been published about this. I don't have on the slide the basic epidemiology, but Phil Wong, who's now the deputy director of our National Institute of Mental Health, found very similar rates of disorder as those that I reported to you about the earthquake in Taiwan. 31% of people had a mood or an anxiety disorder, but as is typical, only about 1 in 3 of those individuals sought care. And the treatment that was received, most of it had already been finished within 60 days. Most of the treatment, even in a setting with a considerable amount of specialty mental health services, many psychiatrists and social workers, even in that setting, most people seek care from their general medical doctor. And as I said, most of it was short-term, and most of it was the receipt of medications to promote sleep, to reduce anxiety, and to treat depression. I wanted to show you in particular this paper called The Long Road Home that we published about the efforts to replace the psychiatric hospital in the public sector in New Orleans after Katrina. Now, it may surprise you that the total destruction of inpatient care in New Orleans amounted to the removal of 140 beds. I know that the number of beds that were destroyed in Tohoku was very considerably greater than that, because we have a system that does not rely on inpatient care. But all the same, you can imagine how important those 140 beds were for the delivery of mental health services in the affected area after Katrina. And over 3 years, they rebuilt those beds. And this provides a story of how those beds were replaced. So for those of you who are in the situation of considering rebuilding, I would call your attention to this particular article. The next slide talks about some ideas about repairing the infrastructure beyond physical buildings like hospitals. In a paper by Griffiths that we published only 2 years ago, a very important lesson is learned that when people are evacuated, the resources should follow the patients and not the hospitals to new locations. Where people go, we should think about the resources that are needed to treat them. And if they are evacuated, we have to reallocate the resources to them. We learned this in the Katrina disaster, and it strikes me that it's a lesson that will have to be learned here, whether it's within Iwate Prefecture or among prefectures in the consideration. And in Katrina, people were removed quite far away from their homes to another state, from Louisiana to Texas. And how we think about moving resources across political boundaries is an important and a challenging rule. But the resources must be shifted, or else people will get less care. Could we see the next slide, please? This one will translate in any language. I wanted to show you this slide as a slight departure from data, because one of the joys of being the editor of this journal is that I not only make decisions about what goes inside the journal, I make a decision about the picture that goes outside the journal. In September of 2006, on the 5th anniversary of 9/11, we devoted the entire journal to a series of scientific papers about the experience of providing services in the wake of the destruction of the Twin Towers due to terrorism. I selected this photograph that was done by Robert Mapplethorpe. He's a very provocative and controversial photographer. Some of his subject matter is different than this picture of the calla lily. His work is very identified with the city of New York. Please look at this photograph. What I saw was that in the center of this lily was a tower. It was a tower surrounded by the petals of this flower, but it was also a symbol to me of the smoke that resulted when the towers fell. But the lily in Western culture is a symbol of resurrection and rebirth. It's a very important symbol, and I think Mapplethorpe was using this, even though it had nothing to do with 9/11 when he did this picture. Why is 9/11 important in consideration for 3/11? I think for a number of reasons. Because we have learned that there are differences between disasters that have natural causes and disasters that have human causes. And that distinction is important in our thinking. Most of us at one point come to terms with the enormity of nature and that she cannot always be tamed. But we like to think that we're better able to control ourselves and our neighbors, but it is not so. And so there are dimensions of disaster that exceed what nature brings us and considerations. And here, in what's been characterized as a triple disaster, the non-natural portion, in terms of the nuclear disaster, has a different dimension. And I would go so far as to say, based on what I'm learning more and more, is that there may be a quadruple disaster. And that is a portion of the disaster that is related to uncertainty and a lack of confidence about responses in the public and private sector to this disaster. And they're important to consider. We learned many lessons from New York City and Project Liberty. The next slide, that slide there illustrates it. In parallel to the very rich mental health system in New York City, following the disaster, they introduced a Project Liberty, it was called. Interesting, my earlier remarks about the Statue of Liberty, so powerful that that was what they entitled the response to the Trade Center disaster. They provided services to 565,000 people who came for care. And this was care in many ways like the community mental health team response to Tohoku. It was on top of what was already available in the city of New York. And some of my colleagues studied whether it displaced services that were already there. No, this was a supplement that complemented the services that were there. These services were able to help people who were affected psychologically by the disaster to return to functioning as they had before. So it provides a lesson about a response to a significant disaster, 3,000 people dying, people being traumatized, and we were able to marshal those services. These, as I said, were specialized or psychiatric specialized services. But there are an array of primary care responses as well, and my next slide just reviews some of them from the literature. I'll only mention them. The first, in recent brush fires in Australia, they marshaled a system of non-psychiatrist physicians with the assistance of consultation from psychiatric specialists to help the people who were affected, burned out of their homes and forced to evacuate the brush fires in Australia. Coming back to the United States, another hurricane, Hurricane Floyd, used a mix of primary care doctors and psychiatrists to deliver the care. This is referring back to my earlier slide, a hybridized approach. And then in Netherlands, in Enschede, in the Netherlands, there was a fireworks disaster, an explosion. Many people were killed, and here they also used a hybridized non-psychiatrist physician, psychiatrist physician consultation approach. And the last, I had already promised you a few more details about something called collaborative care. There's growing experience in the use of this model that was developed for the treatment of depression by non-psychiatrist physicians, but it's being applied to post-traumatic stress disorder. And my next to last slide provides some of the information about it. It's a model applied to depression that was learned with other chronic medical conditions developed by Ed Wagner at the University of Washington in Seattle. It's been used with rheumatoid arthritis, with diabetes, with congestive heart failure, and depression. It was adapted for depression by Wayne Caton, Gregory Simon, and Jürgen Unitzer. And they have done work demonstrating its effectiveness, its cost effectiveness, and the know-how to implement these services in many, many settings. It's a very powerful evidence-based practice. How it is done is through a partnership between a non-psychiatrist physician and a so-called nurse care manager. It's a nurse with specialized training in the treatment of mental disorders who interacts directly with the patient. The primary care doctor writes medication prescriptions with consultation from an expert in psychopharmacology. And as I said, there is very ample data on the cost effectiveness of this service provided by research sponsored by the National Institutes of Health in the United States and by private foundations like the Hartford Foundation and the Haag Foundation. So I leave you with a final thought on the final slide. Is a collaborative care model a way to deal with post-disaster relief in Tohoku? I have no idea if it is the right choice, but I offer it as a possible thing to think about because it works very well in settings where there is very little specialized psychiatric infrastructure. People tend to go to general medical doctors for care, and that's how collaborative care succeeds. So I raise the question, is it an applicable model in a resource-poor area like here? What models work best? I use these three words to talk about how to think about the choices. The one may be a good choice, to completely replace exactly what was there before. That might be good. Maybe what is better is to take what you had already envisioned for care and make it better. But maybe what is best is something that is new, to take advantage of disaster to produce reform. And so I'm hoping for what is best for Tohoku and for Japan generally. Thank you very much.
ありがとうございました。